professor of surgery, chief of the the division of gastrointestinal surgery at UCI, and he's going to talk about something that's near and dear, and he's put a ton of work on this, which is the AFS grading of the EGJ integrity, improving the Hill grade classification.
Are everybody awake? Put your hands over your head and just stretch. There you go. Do your home stretch, okay? I'm a little excited about this presentation.
They still got me out.
I think you're good now.
Yeah.
Can, right?
Okay.
Everybody can hear?
Oh,
Oh, we're too close to
Not
me.
sure.
I think it was the stretch that did it.
Yeah, the stretch did it. That's right.
How about now? No? Testing? Testing?
That's
Good.
All right.
All right, so I'm excited about this project. This is the AFS endoscopic classification of the EGJ integrity. It's a mouthful, but really it's comprised of the work of the Clinical Practice Committee, and that's why I'm so proud of this. And even though I'm standing up here presenting this, these are the real worker who's listed every there, including the rest of the people on the Clinical Practice Committee. Let me tell you about the Clinical Practice Committee. It's being run by myself and John Clark, but we have 91 members and we have monthly meeting. This is our philosophy. If we believe that we are the expert in this foregut space, we need to bring the science. We're not just coming here and regurgitating the science, but we need to bring the science. And it has to be original work from the AFS. We're working on the Hill grade, et cetera, but we have many more work to be done, and it's kind of listed there, okay? So if you want to get involved, we're looking for a few more bright minds. So this is the product also of the Clinical Practice Committee, and this is the labor of love. Why? Because it took us quite a bit of work to get it all together, and this is going to be coming out in the spring of 2023. This is the AFS textbook of foregut disease. And it's just not give you the most up-to-date science out there, but it also give you original work by the author. So I would say this will be the leading book for years to come. Okay, let's talk about this. The American Foregut Society white paper is going to be coming out very soon in foregut. There's a lot of disclosure that was on there, but I can tell you that none of that disclosure impact how we decide to change this grading system. Hill grade was originally described in 1996 by Lucius Hill, a thoracic surgeon, esophagologist. It is a classification of the flat valve. However, clinically, it's not well accepted, I can tell you that. And there's a lot of skepticism about the usefulness or the relevance of this grading system here. So how do we begin this? We begin this through collaboration. And we talk about collaboration here, this meeting, multidisciplinary conferences. But you know where collaboration truly exists? It's inside the OR. And CTIF was the first time where an GI and the GI surgeon are in the same space, inside the OR. Because before that, you know, says, okay, this patient goes to you, GI, this patient goes to me, GI surgery, and we separate our way. But this is the first collaboration we work on together inside the same space, right? So now we see the Hill grade that was reported, and then now we see the Hill grade on the laparoscopic view. Might be Ken Chang coming in the OR, or we have training session all the time whereby we have, you know, faculty coming in to review the CTIF. So what we found out is that there is a discordance in terms of the reading of the Hill grade and what we found on laparoscopic. So a year ago, I was asked to take a leadership course. And what it says is that, listen, when there are failure or issue that arises, it's not the individual fault. It is the system fault. So what's my conclusion about this? This is not Ken's fault. This is not Ken's fault, right? Because he would read a Hill grade 1, but laparoscopic view, it's like this, etc. So it is the classification fault. So we do recognize that, and then we jump directly on trying to fix this. So this is a Hill grade, very simple. Grade 1, 2, 3, and 4. everybody kind of knows this, but it does give you the schematic view, it gives you the endoscopic view, and it gives you descriptive view. I'm just going to point over here because it's just easier. So take a look at one. Schematically, that's over-exaggerated. Human anatomy doesn't occur like that. The valve length is not that long, so that's one. This endoscopic view, personally right now, I believe this is actually a Hill grade 3, okay? It's not closely approximated, so this is a very poor example of what a flat valve should look like. I'm gonna show you what a flat valve should look like, okay? And then the description, we have to come up with a better terminology. It can't be just a ridge of tissue, because that's poor way of describing something, enhance inter-observer variability. 2, and this is the pet peeve, originally, how we actually jump into this, changing the classification is this Hill grade 2. Take a look at Hill grade 2. This is supposed to be normal. Look, green. This is supposed to be a normal flat valve.
He's a nice guy.
You can see here, very long flat valve here. However, if you take a look at the endoscopic finding here, that's not normal. There is no flat valve here. And you can see here, it's thinning, effacement of the flat valve. And so this is the why we actually initiated upon this changing of the classification. Number 3, it says here, nearly always present. And you can see here, schematic diagram, there is no hiatal hernia present. 4 actually looks pretty good, right? It says here, a hiatal hernia is always present, but the problem, it doesn't give you the objective parameter where an individual says, you know what, that's a 4. So if we believe that GERD is an anatomic disruption of more than just a flat valve, it's actually an anatomic disruption of the hiatus. So upon going to this, there are several principles we have to follow. 1, we minimize major changes that require learning of a completely new classification because that's too disruptive, because we're so ingrained into Hill grade 1, 2, 3, and 4. And this says it best by one of the reviewer in Foregut, I think this is Dr. Phil Katz, fix only what needs to be fixed. Don't go wild on this, just fix what needs to be fixed. And then lastly, make it anatomically accurate and clinically user-friendly. So this is our method, 13-member working group. We're tasked to do this job. And upon going to this, we decide that, listen, if we're gonna make minor changes, it's just a revision. We're gonna revise the Hill grade. But if we're gonna make a lot of changes, this is a new classification. Obviously, you know the name, so there's a lot of changes. And then this is a modified Delphi method. We came up with straw proposal and reiterative multiple subgroup discussion. But before we do that, we have to get the record straight. We can't do this project if we can't agree on this. So we decide to come up with a position statement. This is the AFS position statement on the component of the anti-reflux barrier. We actually don't have a statement that by any society out there. So this is actually the first statement. Okay, so the survey is open-ended question, 24 question on the component anti-reflux barrier, and please comment on the Hill grade, both the schematic diagram, the endoscopic image I show you, and the description of the Hill grade. So they just said, hey, speak your mind, what do you want to change? What's bad, what's good? So we sent it out to all the clinical practice committee member, the expert panel, the 13 people, and then 47 respondents. That's a pretty good respondents. And you can see here, 21 GI and 26 either GI or thoracic surgery here. And majority, 90% says, hey, this is a worthwhile effort. 90% says, you know what? It's important. So the first thing we work out is the component anti-reflux barrier. This is SAGES, and they said that the exact nature of the anti-reflux barrier is poorly understood. Current view is LES, diaphragmatic crura, and the phrenoesophageal ligament. I like this slide a lot because it says the barrier to reflux is more than LES, and a lot of us shows this. You have seen this, right? In this meeting, Ken Chang have shown this, that the dysfunction, the combination, the two anti-reflux barrier, are the LES and diaphragmatic crura. Where is the flap valve? Where is the flap valve? Lucius Hill described the flap valve early on in 1996, and you can see here, it's a one-way flap valve from the greater curve going to the lesser curve here. Blair Joe, Peter Corrillas, John Hunter, Swanson has demonstrated that, listen, if you accentuate this valve in anti-reflux surgery, you're going to get good anti-reflux control. And that has been proven. And then further on, if you disrupt this flap valve by doing a surgical operation such as the laparoscopic sleeve gastrectomy, this is a systematic review, 46 studies, over 10,000 patients. The forest plot demonstrate increased post-operative GERD in 19%, de novo reflux in 23%, long-term prevalence of esophagitis in 28%. So their conclusion is that the sleeve gastrectomy caused disruption of the anti-reflux barrier. They didn't specifically say which of the anti-reflux barrier, but it's likely related to the flap valve. And you know, the flap valve is not new. This is a publication in 1962 demonstrating these are the three mechanisms listed there, and similarly in 1958, kind of showing you that the flap valve is a critical aspect. So we asked all the survey, what are the components that's important? And it listed here. Everybody says, hey, these are all important here. But then we asked, what are the three most important? The one that came out is the LES, the crura, and the gastroesophageal flap valve. Well, what about the rest? The intra-abdominal esophageal segment belongs to the flap valve. They're interrelated. You can't separate one or the other, and same thing with the angle of His related to the flap valve. And the phrenoesophageal is related to the crura. So there you go. This was the straw proposal. And then we went even a further extension saying that, listen, is it a physiologic barrier or is it a mechanical barrier? And this is our result. So the next time you write a book chapter, a paper, anything, you're going to have to stress the component anti-reflux barrier if you're going to be talking about reflux. You can't be describing a paper without talking about this. You should quote this. This is AFS copyright, and then you can actually use this if you want to. You can take a picture of this if you want to, but it will be in the paper that's going to be coming out. So this is our final AFS position statement. And I kind of like to look at this in a different way, right? We kind of look at it like this because truly these are all interrelated. If you have a defect in the crura, you're going to have lost intra-abdominal esophageal segment. You lose your LES tone because it's up in the intrathoracic pressure. So I asked Christy Dunn the other night about this question about what if you fix the crura? You're going to fix the hiatus here, and you can see here that that's a Hill grade 3. Will that have an effect on the flap valve just by fixing that? No fundo or anything. And she came up with eloquent answer, says maybe, maybe. But what we found out is that there is an effect. Just by fixing the crura and having an intra-abdominal segment, exactly what we do here, you do fix the flap valve automatically. But it's not long-lasting. That's the problem with hiatal hernia repair alone. It is not long-lasting, but there is an interrelationship between the structure. So there you go. You can see here, if you mess up one of the things, you mess everything up. But if you restore one thing, you will restore because everything are interrelated, these three. So the new classification, the name is listed there, but we have a shortened version. The shortened version is the AFS HG, hiatus grade, because our focus is not just the flap valve, it is also the hiatus. So this is essentially the summary of what the difference between the Hill, flap valve only. AFS is the flap valve plus the degree of hiatal disruption as measured by the hiatal diameter or axial length. But before we even jump into there, this is critical, right? Because there are so much issue of inter-observer variability in reading of the Hill grade. So we said this is actually the same patient. Same exact patient. This is about 30 seconds later, and this was the original. And you can see here, If you just stay with the left side, you're gonna undergrade that, right? And the question, how do you get to the right side here? I have a quick video demonstrating this. And it doesn't take that long. So this entire video is only, I think, about a minute and 30 seconds, but you can see what we're trying to say. For you to get an adequate, you have to do maximal insufflation, flatten out the rugal fold, but you got to do a little bit more than that. You have to do what's called the provocative maneuver, and we'll kind of show the provocative maneuver a little bit. Essentially, the tip of the endoscope is going on to the lesser curve. And we'll go over the nomenclature in a bit, but once you get adequate insufflation here, you have to do the provocative maneuver to see if you can provoke it to induce. And some people says, hey, is that because, hey, physiologically I induced that? No, you did not induce that. You just demonstrating the anatomic defect that's there. And sometimes you can't do it, but sometimes you can do it. For example, here it is. It's called push-off. Get to the lesser curve, push-off. Get to the lesser curve, push-off. And the more push-off you do, you can start to see that the hiatus widen. And look at the involution now. Now you have an axial length of about 3 centimeters, and the diameter is about 2.5 scope. So you can see there is much different than when you just enter. So you gotta have basic endoscopic nomenclature. You can see here anterior and posterior. Lesser curve, greater curve. This right here in the omega shape, and that's how we describe this full lip, and that's the lip of the flat valve, and this is the body of the flat valve, and this is the length of the flat valve. These are the terminology we're gonna use instead of ridge of tissue. When you don't have a flat valve, people think this is a flat valve? The answer is no, that's not a flat valve. That's an illusion if you think that is a flat valve. It's called the EGJ mucosa fold. There is no flat valve there. And then if you have these pillar, you gotta get your orientation correctly. That's the left crural imprint, and the other one is the right crural imprint. Okay, let's get to the classification. One thing that Lee Swansam keep asking me, why I don't understand the color coding. The color coding is there. I can't remember now who came up with the color coding. I think it's Barham. But nevertheless, the color coding give you an easy way to say, hey, what's good and what's bad? That's it. Look, is this good? Yeah, it's green. Is this bad? No. Well, yes, it's bad. Okay, what's in between? Yellow and orange. That's it. It makes things so simple. And how is that compared to the hill grade? Look, hill grade, both of these are green, and then you have orange and you have red. There is no yellow. The new one is the yellow one, okay? The new one is yellow one. And number 2, look at the yellow line. Focus on the yellow line. The yellow line is the line of relativity. And what is that? It's the line of the hiatus. Everything has to be relative to the hiatus. So the location of the esophageal gastric junction relative to something, that's called the hiatus. There it is. EG junction below the hiatus. EG junction at the level of the hiatus. EG junction up to 2 centimeters and then above that. So everybody kind of understand that? We did not have in Hill. Look where the diaphragm is. The diaphragm is all over the place. We have here what's called the line of relativity. And here is the final hiatus grade I present to you. You have a laminated version of that when you got in here, but it's hard to understand that by just looking at that thing, right? So that's why I'm here trying to explain to you. Look at this valve. Full, thick lip valve taking the shape of an omega shape. You don't have that when you don't have a full lip. Number 2, it's L0, D, and F+, right? So what does that mean? These are the component, axial length, hiatus diameter, and F stand for the flat valve. Either it's present or it's absent. That's it, okay? So everything here is green. The next one, AFS grade 2, is partial disruption. And this endoscopic view, and you said, hey, wait a minute, that's a Hill grade 2. You are correct. You are correct in saying that's a Hill grade 2. We know that. But what we're saying is that Hill grade says Hill grade 2 is normal. It's not a normal endoscopic finding. This is a pathologic finding because with Hill grade 2, you lost the intra-abdominal segment and the D has widened. This is what John Lipham keeps saying that, hey, there's crural separation. This is exactly what it is, crural separation. You don't have the actual axial component yet. This is a transition between grade 1 and grade 3, which is not available in Hill grade. And you can see here, the minute you lost a flat valve, that's it. So flat valve is either green or red. There's no such thing else. There's no gradation. Either you have a flat valve or you don't have the flat valve. AFS grade 3, moderate disruption, L0 to 0 to 2. So meaning now the axial length here, it's about 1.5 or 2 centimeters. You can see here, D, 2 to 3. So you can see the scope here. It's about 2.5, okay? No flat valve. And then grade 4 is anything greater than 2 centimeter axial length, greater than 3 diameter, and the flat valve is lost. So essentially, this is the AFS hiatus grade with a statement that you have to have full distension and have done the provocative maneuver, and the worst finding determines the grade. So this is kind of summary. I'm not going to go through all this of what are the difference between. This is going to be in the paper. You can read about it. Okay, which AFS hiatus grade associated with reflux but without the presence of hiatal hernia? Which one? Did you pay attention? Which one?
2.
2. Correct. The AFS 2. What is the first disruption of the EGJ based on the AFS hiatus grade? Which one occurs first?
Hiatus diameter.
B.
B. That's correct. Wow, everybody's paying attention. What is the AFS grade, hiatus grade for L1, D4, F minus?
We just took it up a notch, didn't we?
Yeah, we took up a notch a bit. But once I show you, you're going to say, okay, wow, very simple. Look, okay, L1 is here. Okay, it says, hey, the minute you have axial length, you got to jump. There is no such thing as, wow, I have a good flat valve and a 1 centimeter axial length. It used to be, that's the case. It doesn't exist anymore. The minute you have L1, it jumped to grade 3. But the minute you have D4, then it jumped to grade 4. And the worst finding determines the grade. So it's truly grade 4. So in summary, we came up with the AFS position statement on the component of the anti-reflux barrier. Please use it. And then now we have a new classification. Your job is to bring this back to your own institution and spread it. You can spread it widely. You can spread it on social media, whatever you want to do. But I think this classification is much user-friendly. So thank you.
I think we can officially say mind's blown, and I'm going to make a provocative maneuver and ask Nin to sit